I'm gonna get us started, and it's my great pleasure to welcome Vish Viswanath, who's a faculty member at the Harvard T.H. Chan School of Public Health, where he's the lead professor of health communication. And Vish has, I mean, if you've written anything in communication on most topics, you probably at some point ran into his research, but I think his research, it's fair to say, also sits squarely and has always sat squarely between where societal problems are and where communication as a discipline is, meaning how can we translationally use the kinds of findings that we produce within the ivory tower to solve social problems, especially for and I will use the term just so he can contradict me in his presentation, hard to reach audiences, which I know is a term that you really don't like. And I think the reason why you don't like it is extremely insightful. And I know we're going to get to that. So that's why I'm using it, even though I know I'm not supposed to use it. So I learned that from you. He's one of the most highly decorated people in our field, fellow of the International Communication Association of MAPOR, the Midwest Association for Public Opinion Research. And I could literally, we just were joking about lengthy CVs before we started. I could go through lots and lots of accolades, which I won't, but I encourage you to look them up online. And will not take any more time away, Vish, from your presentation. I've heard you speak to the topic that you're going to speak to more recently, and I know this is going to be really excited. So thank you for joining us.
Thank you so much for having me, Datram. It's great to be talking to you, Madison and Wisconsin. UW is one of my favorite places unless it comes to sports, because I was a gopher, and every time I went to a game, somehow the Badgers used to beat Gophers, for some reason. So,
it's still like that.
Something. It's nice to be in a talk with Datram, whose work I admire a lot, and Dominic. So it's great to be a part of this conversation with you. So my talk will be. It might sound like a measurement and methodology talk. It is a methods talk. But actually, there is a substantive reason behind this. At least I would like to think there is a substantive reason behind this. And so the question, a colleague of mine, Nancy Krieger, often says, if you care for something, you'll actually measure it. If you don't care for it, you don't measure it, or implies something to that line. If you think about it, as Datram pointed out, my own work focuses around issues of inequalities and you look, and in the area of health, as one application of science communications, if you look at the data are very clear that those from lower socioeconomic position, or socioeconomic status, or lower social class, whatever the term people want to use it, some measure of stratification. Or if you're if you're a racial and ethnic minority member, you are much more likely to suffer disproportionately from disease burden compared to other groups. And those data are extraordinarily well documented, have been well documented for the last 30 years or so. This is one exemplar of that. If you look at smoking, people who are continuing to smoke, people are from a lower socioeconomic position. They smoke, say, for example, almost 30% of the people under the poverty level smoke. If you look at the countrywide data, in the country, it's somewhere between 11 to 16%, depending on where you are. This is the latest data. I just got it, for the class, so that it should be interesting. If you look at the demographic characteristics of people who began to get vaccinated, the initiation of vaccines, again, you see that racial and ethnic minority groups were late to begin with compared to groups who are white and non-Hispanic, right? And you can continue to document, this is something Datram and I have been talking about in the last, for the last few months, that COVID-19's morbidity and mortality has been much more associated with lower SCP groups as well as racial and ethnic groups. And it's always a puzzle how is it that we did not know that it's going to affect them disproportionately compared to other groups, even though we have 30 years, almost 25, 30 years of work, which shows anytime you have a pandemic, certain groups are much more adversely affected compared to other groups, right? So it should not be a surprise, but we continue to get puzzled about it. This is one of those questions that makes me extraordinarily angry. As a scientist, I'm supposed to be neutral, I guess, but I'm not when it comes to issues of poverty and inequity, So, and this is a puzzle. And then people talk about big data, right? And everybody talks about how promising it is and what miracles can be accomplished with big data. All these promises that people make with wearable technologies, etc. I'm not against any of those things. All those things are great. But one of the challenges we face, especially when it comes to a question like this, and this is what I want to answer today. This question, I want to find answer to this question. How is it that we failed as a nation to anticipate that the adverse outcomes will likely happen among lower socioeconomic position groups and racial and ethnic groups? And that's where I want to focus a bulk of my talk on. And as you know, I think one of the challenges we have is that although people from lower SCP groups face the burden of health disparities or disease burden, they're often underrepresented in the large national surveys. And that's where the problem lies. People say they're challenging to recruit, and Dietram had that provocative phrase, they're hard to reach, and that's a common impression. They are difficult to reach by phone or email, and then there are, of course, literacy or numeracy problems or concerns. And that leads to data absenteeism, what we are calling data absenteeism. Basically, are the data we have, are they representative of the population groups we want to study? And the other way to put it is, whose data are we collecting? That means, who are we paying attention to in our society and in our system? And so we have all these data on the basis of which policy decisions are made, scientific decisions are made, which is leading to this kind of a data chauvinism. That the data we have is helpful enough to make decisions without asking questions about the quality of this data. But if you think about it, our argument is that lack of data on lower socioeconomic position people or groups or individuals will lead to absent or incomplete or even misleading generalizations. And that's the problem we have, whether it comes to communication access or whether it is communication behaviors, whether it is processing information, whatever it is, particularly in science communication we are dealing with, our generalizations, I think, are questionable if they're not representative, if they don't have enough number of people from a lower socioeconomic position or racial and ethnic groups. So our question is, are lower SCP individuals hard to reach or are they hardly reached, right? That is the question we should be asking, because there are ways we can increase their participation. And that's what I want to show. When you increase their participation, what will happen? Through various projects, we have gone out of our way to recruit people from lower socioeconomic position, and that will show you why the results could be different. And if we make those efforts, I think. So I will draw from our projects. So one example is a project we called Project Impact, where our focus was whether we can change the media agenda and public agenda to address the complex problem of health disparities. So most behavioral interventions focus on individual behavior change. Let them exercise more, let them eat more, let them eat healthier. And our argument is, well, that's very good, we should do that. But what about the environment in which they operate? And is the environment conducive for that kind of a behavior change? And how do we create a media environment that is hospitable to those ideas? So, and because media environment, hospitality or hospitable media environment could also lead to potentially policy changes. So in that project, we conducted it in Lawrence, Massachusetts, which is 80% Latino. So it became immediately clear to us when we wanted to do a public opinion survey, there was no company out there that could collect the data for us. in a way that can represent the community, particularly when you have a large number of immigrants, some of whom, a substantial number of whom are also undocumented. They're unlikely to answer questions. So what we did, we explored it quite a bit, and absent a public opinion firm that can do it, we actually did our own survey. And what we did was actually, we thought a lot about it. We worked very closely with our community partners. It is what is, I'm sure some of you have heard of the phrase community-based participatory research, which means the community partners define the problem with us. We have been working with them for 15 years now. And with the help of partners, we actually recruited high school students who are about to graduate and use this as an exercise, as a science exercise for them. So we actually taught them how to do a survey. We had classes for them, how to ask questions, how do you do interviews, what is probability-based sampling, why do you have to stick to a protocol to ask these questions. We trained them, and so the two things that happened as a result of that. One is we built capacity in the community for survey research or survey interviewers. And so our partners were able to tap into that expertise for their own work. Plus, we have been able to obtain the kind of data we wanted it. So we would actually send them out into the neighborhoods after training with a supervisor who was actually a trained survey researcher from a lab, and each with 2 members. And they would go around with a particular protocol in these neighborhoods and start collecting data. It's very interesting trying to explain to them why they can do certain things, why they couldn't do certain things. So someone would say, I knocked on this door, no one was at this house. So why can't I go to the next house? Because I can see that door open. I can see somebody's in there, and you're trying to explain to them, no, you have to skip 2, 3, 4 houses to go to the next one. And so it was an interesting exercise trying to teach them. A lot of them actually went on to community colleges or other kinds of careers, using this. And I should say one of the more poignant stories is Lawrence is only 35 miles from Boston. So when we brought them to Boston as a reward for what they have done, we paid them. It was not unpaid. We paid them nice wages for a summer job, but we also brought them in to thank them to Harvard. For the first time in their life, they were actually visiting Harvard. So in fact, one of their parents actually baked a cake for us. So it's just a way of building capacity, but also collecting data locally. So what is the result? If you can look at it. So we managed, because of this approach, we managed to get a sufficiently large number of people from lower socioeconomic position and racial and ethnic groups, which are below, compared to what you would get from, say, Health Information National Trend Survey or the Pew Internet surveys. So the idea is, otherwise you wouldn't be able to get sufficient number of people with a lower income or racial and ethnic groups, right? Without doing that. And we were able to collect these kinds of data, which eventually we used to create training programs for the community-based organizations on media advocacy and how do you frame inequalities for media and in your communications. That's one. In Project Clear, FDA came to us and said, we have a national policy signed by President Obama, the Prevention of Tobacco Control and Smoking Prevention Act, and we, as a part of it, we were going to put labels, warning labels on cigarette packs, but do they work across all socioeconomic groups and racial and ethnic groups? This is a federal policy. Policy is a blunt instrument. Will they work across every group? So what we did in Project Clear, again, our interest was, what impact will these graphic warning labels have on vulnerable population groups, particularly when predominantly this is the group that is most likely to smoke, right? So these are the warning labels that the government was going to introduce. So we actually started testing these warning labels in field experiments with an oversampling of this group of people. So what did we do? We tried to go out of our way to recruit smokers and non-smokers in these groups, particularly with focus on Spanish speakers, blue-collar workers where smoking rates are very high, LGBT where also smoking rates are higher than normal, and young adults. Young adults are very tricky when it comes to smoking because they don't consider themselves smokers. They consider themselves as social smokers. and intermittent smokers. So we wanted to also recruit them. We work with our partners. We work with community colleges in our communities, in 3 Massachusetts communities. We went to the federally qualified health centers because we have partnerships there, and spread the word with the social networks. And we confirmed them. This is a whole story by itself. Even when they sign up and enroll for work, a number of their life conditions preclude them from making it to the appointment. So you have to remind them, you have to work with them, you have to talk to them to ensure that they show up for these surveys and experiments. Then we administered these surveys on an iPad. Actually, this was, I think, one of those pads of some kind, and I don't remember which one, but it's somewhat cheaper that was programmed. And then so now you can look at the data. Again, in Project Clear, we managed to recruit people from a lower socioeconomic groups compared to in a higher number of people from these groups compared to again US Census and HINTS, etc. And then we were able to actually study the impact of these warning labels, each of these warning labels, and we were able to conclude. Let me just say this: we were able to conclude in a very welcome news, actually, that these warning labels are unlikely to exacerbate inequalities among people. In fact, the warning labels are much more likely and powerfully likely to work with a lower socioeconomic position group. So you look at the odds ratios of 1.7, or some high school 1.9, among Blacks it's 2.1, Hispanics 2.3. All of it is good news, which shows that compared to whites or higher socioeconomic position groups, these warning labels are actually likely to work more among the lower SCP or the racial and ethnic groups, right? That was, again, the data we were able to provide to FDA on these issues. So again, that's the story. I'm going through it quickly just to make room available for discussion, and also so forgive me if at some point you feel that I'm going too fast, stop me or raise your hand. I can slow down a bit. Between my accent and my speed, you may find it difficult to follow me. So one of the things we found out as we were doing this is we wanted to follow up 6 weeks later to see if the impact of these warning labels endures beyond the exposure at that moment. And that is a question. So when we collected data from telephone numbers from them and said, we'll call you back in 6 weeks. And we provided, obviously, we are providing incentives for participating in this experiment. We found out that among the 463 people who wanted to work with us, who are willing, who said we can resurvey them, we were able to complete with about 70% of them, but with 137 of them, we couldn't reach them despite number of attempts. So we were puzzled. What is the problem here? And we immediately discovered a whole host of problems. Some of them we were not able to reach. Some of them were hospitalized or incarcerated. Some people, the phone was not in service anymore. Our voicemail was full, or a wrong number, or no answer. Some of them are working on 2 jobs, 3 jobs, and it was just extremely difficult to get hold of them. So we did an additional follow-up survey to find out what are the challenges they face in staying connected to telecommunication services, particularly phone in this case. And we found out, a large number of them had problems. Phones were out of service, phones were not working, phones had to be repaid. Some people, were not able to use it for a variety of reasons. Some people had, service cut off for lack of payment of bills. And in fact, in some cases, even phone numbers changed. Imagine how precious our phone numbers, right? We don't want to let that go. But in some cases, they couldn't just keep the phone numbers, right? And of course, some of them had problems using a tablet, which is not at all unusual, for certain groups of people. So, and the last project I want to show, but all these lessons are, were very valuable. The last project is a state level survey called Mass HINTS. And in the Mass HINTS project, HINTS stands for Health Information National Trend Survey. The National Cancer Institute came to us and said, we collect national level data, but within the Dana-Farber Harvard Cancer Center catchment area, can you collect information on cancer communication behaviors of specific underserved groups? The information, we don't have that information. It was a national competition, and about 10 centers from the cancer centers were funded, and one of our centers, our application was also funded along with them. So what did we do? We actually had 3 types of samples. We had a probability-based sample from a company called GFK, and then a non-probability sample where we wanted to oversample rural residents because rural residents are ignored often. And then we had a community-based sample where we gathered data from very diverse community locations. Specific, and these are the locations, where we went and started collecting this data. Primarily, in addition to the usual group of people, we were interested in African Americans, Latinos, blue-collar workers, homeless, and the lower people from a lower income, lower socioeconomic position. And I won't go through all the questions for the survey, but we went into the localities, my team, and started collecting this data for the community sample. And this is the entire catchment area for the Dana-Farber Harvard Cancer Center. Now, what I wanted to say is in the probability-based sample, this is a sample we got, 76% white, 6% African-American, 9% Hispanic. In the community-based sample, we managed to get a larger number of African-Americans, a larger number of Hispanics, a larger number of people under $20,000 annual income, people with less than high school education, right? It's not that one is right, the other is bad. It's just that we wanted larger numbers to do that kind of a subgroup analysis within each groups. So why does it matter? I will end with 3 slides to show you why these data matter. We asked people about smoking. Do you smoke? Have you ever smoked 100 cigarettes in your lifetime? In the probability sample, 40% said in the lifetime they smoked cigarettes, 100 cigarettes, but currently there are only 11% are smoking. That's about the national rate. But if in the community-based sample, 40% are current smokers, right? Among whites, these are blue-collar whites, 57%, African-Americans, 35%. The national rates are much lower. Latinos actually smoke at much lower rates, but in our sample, again, 32%. Poorest people, from 53%, and homeless, 76%. Right? So these are the kind of numbers you can get if you are doing this. We asked them about mammography. Are you getting screened? In the national sample, or in the probability-based sample, 96% said they have got screened at least once. In other groups too, the numbers look good, except for the homeless. Are they adhering to the current guidelines? Generally, the numbers look good, again, except for the blue-collar whites and homeless. And the reason these numbers are somewhat better is because we have a national policy to reach out to these groups. It's called actually the REACH program. But when it comes to other issues like health service utilization, look at where they go. Had a time in 12 months, could not see a doctor due to cost. Only 7% here, close to 20% in other groups, 30% among the homeless. Usually you are discouraging people from going to the emergency rooms, and you want them to go to the clinics or doctor's offices for treatment. Among the community-based sample, you can see a larger number of them, end up in emergency rooms. When it comes to communications, have you looked for health information? All of them look for health information. But it takes too much effort to find information. 1 in 4, close to, in the probability-based sample, yes. But in the community-based sample, among whites, blue-collar whites, African Americans, Hispanics, below 20,000 annual income, 55 among homeless, the numbers are much, much higher. They had difficulty getting that information, even though they all wanted health information. They felt frustrated in searching for health information. Again, look at the numbers here in this corner. It is too hard to understand what we call as innumeracy and illiteracy and difficulty, health literacy issues. Again, these numbers are much higher among the community-based sample. Concerned about information quality, obviously all of them are. So the point I wanted to say, and I want to stop here, I know I went very fast, is, this is just not a measurement or a methods presentation or a methods problem. It is a problem of substance, of policy and practice. If we are really serious about addressing, inequalities in our society, if we are really serious that, science communication should reach out to all groups equally, that everybody should benefit from scientific revolution, irrespective of their background, then the first thing we want to make sure is, are we measuring the right people? Are we getting the right people in our measurement in order to make some decisions about our programs or our policies? That's the point, basically. And the last point I want to see is, these are not, as I said, hard to reach people. These are actually people who are hardly reached because we don't make sufficient efforts. The excuses we get, I'm not saying excuse, that's not fair. The reasons we get is it costs more, it takes more time, etc. Of course it takes more time. Of course it costs more. But if we value equity as a principle, guiding principle, then it is worth making that investment. Actually, it is much more expensive to ignore these groups in the long run. That's just the point I wanted to make, and that it is doable, and it is very desirable to do this. Thank you.